Hi, Leon. How are you doing today?
Good, Ginger. I didn't take advantage of Fat Tuesday. It was just a regular Tuesday for me. So
Oh, no. I ate a lot of king cake, so I made up for it.
Al didn't send me any, so I didn't have any.
Listen, we are so happy to have you here with us again today. It's going to be an incredible webinar. But you've been one of our dear friends for many, many years. You're well known throughout the industry. So we're always happy to have you. And I know that you and Kyle have known each other for many years as well, so it makes it extra special. But if you don't mind, let's go ahead and dive in. Tell us a little bit more about what you do and how you can help all of our attendees today.
Okay. I'm with Fast Funds. We're one of the first and longest and most trusted litigation funders in the industry. We've been serving the needs of plaintiffs and attorneys for over 25 years, which I can't think of another company with as much longevity. We provide non-recourse funding on a case-by-case basis. Myself, I bring over 17 years of banking and finance experience before I jumped into the litigation industry. For several years, I've worked with service providers, vendors, and directly with law firms as well. I've only worked for the good guys on the plaintiff's bar, so only supported the plaintiff attorneys, and so I've seen firsthand how uneven the playing field is with plaintiff attorneys having to work on contingency. They have to pay their own expenses upfront on all cases, and they're the last ones to get paid. Meanwhile, the defense gets all their bills paid for by the insurance company, including their attorney fees and their case expenses. So this creates a culture where there's no urgency on the defense side to resolve a case sooner than later, because the more they bill, the more they get paid. And they also will try to outspend the plaintiff's attorney as a means or a strategy to try to get them to accept less than their client's case is worth. So for this reason, we've developed a unique funding product for plaintiff attorneys exclusively to help level the playing field. Unlike other lenders and other finance companies who require a personal guarantee or a lien against your attorney fees or an interest in your entire portfolio of cases, we've developed a program that is similar to how the attorneys work. It's on a case-by-case basis, and it's non-recourse. So if you've got a great case, or if you got several great cases and you're having a hard time deciding which one to work in, which one to work up first, we can help you out. You choose your experts, whether it's your life care planner, your demonstrative aids, your TBI, neuropsych evaluation, whatever the case may be. Give us a call. We'll evaluate the case, and we can help fund not only that case, but many other cases. That way you're increasing the value of your portfolio as opposed to just one individual case. So you can increase your fees, you can decrease the amount of time in litigation, and we would love to partner with you on that. So I'll put my information in the chat box. It's been a great honor working with the Connectionology attendees the last several months. The response has been great. We've been able to help a lot of attendees and look forward to continuing.
Absolutely. Thank you so much, Leon. We love working with you, and I highly suggest if you guys have any questions, or if you just want to talk to Leon, ask him for his advice on things, maybe some cases you're working on, just call him. He's going to put his information in the chat, and then I'm also going to provide it to you after the end of the webinar. So thanks again, Leon. It was so good to have you with us today.
My pleasure. Thank you. Have a great webinar, guys.
Thank you. And then also another one of our wonderful sponsors is Paul Luttrell with Strategic Relationships. And he's going to come on towards the end of our webinar to tell you guys a little bit more about what he does. But we're very grateful to Paul, and I'm excited for those of you to meet him who have not met him yet. And then obviously a big shout out to HMR for doing this webinar with us. We couldn't have done it without you guys. I know you're going to hear from Kyle in just a few minutes, but we do have a special announcement later on in the webinar, because today is the last day to win a Mardi Gras king cake from New Orleans. And one of you is going to be the winner of that. So I'm very excited to share that announcement with Kyle towards the end. Now, if you have any questions, please write them in the Q&A box down at the bottom of your screen, and we'll be able to address those. But I would like to go ahead and get started and first go ahead and introduce one of our incredible moderators, Kyle Kinberger, who again, most of you know, but he's the National Sales Manager for HMR, and he manages sales operation around the country for this organization. He currently oversees the daily operations of business that's done in 39 states. And they currently operate, and he has been with HMR since 2012. HMR has been an industry leader in medical funding for the last 9 years, and he's continued to expand this network of thousands of medical providers and attorneys nationwide. Also, HMR has the opportunity to fund several thousand cases, and that number just continues to grow year after year, with a primary concentration on funding catastrophic injury cases for plaintiffs who are uninsured. So Kyle's definitely a great person to reach out to, and just a good person to know. He works with several different specialty providers that include orthopedic and neurosurgeons, interventional pain management specialists, and inpatient and outpatient traumatic brain injury centers. I do want to tell you that we did 2 incredible TBI webinars that you can find on their website, as well as the link that I sent you guys before this webinar. Highly suggest to go back and watch those, including this webinar, which we will have available for you to view again. So anyway, this is definitely just one of the companies just around the country. They're willing to help fund large brain injury cases for patients who are involved in litigation. And as a non-recourse medical funding company, they do not charge interest on any of their cases where this would be involved, and they truly share the risk on catastrophic injury cases with plaintiff attorneys around the country. So I honestly cannot say enough good things. I'm very excited about this webinar, and I hope that you guys enjoy it. Thank you, and let me know if you have any questions.
Great, thanks so much, Ginger. We are really excited about the webinar that we have today. It's kind of backed by popular demand. We did the first 2 installments with Dr. Snyder and Hugo, and just the response was tremendous. And in those first couple of webinars, we were really drilling down into advanced neuroimaging and DTIs and all of the components that go along with it, to not only identify traumatic brain injury cases, but also to help plaintiffs' attorneys like the ones that are on the webinar today. So again, backed by kind of popular demand, this installment of the webinar series is going to look at imaging of acute spinal trauma, including whiplash, and how that relates and ties into brain injury as well. If you all have questions along the way, which has been a big thing in the previous 2 webinars, we're going to do our best to answer the questions as we go. So we might take little segments where we pause and try to get as many questions as possible. Just put them in the Q&A box, and I'll make sure that I'm monitoring them and we get everybody's questions answered. So with that, we're going to get started. It's my pleasure to introduce first Hugo Chanez. He is a partner at Mitchell Sanchez in New Orleans, Louisiana. He holds an LLM from Queen Mary University in London. He's practiced in the United Kingdom, the European community, as well as the States. He is a fellow of the American Board of Trial Advocates program of Harvard Law School. He is also part of the National Trial Lawyers Top 40 Under 40. He has a national practice, which has a heavy concentration in prosecuting traumatic brain injury cases. And he does it in several states, including Louisiana, Georgia, Florida, Texas, Colorado, and Illinois. His efforts have yielded several high-profile TBI cases, including multi-million-dollar verdicts, awards and settlements that have and can withstand the appellate scrutiny. In 2005, Hugo earned his Bachelor of Arts degree from Political Science at Tulane University and was a member of the Alpha Sigma Lambda Honor Society. In 2009, he earned his Juris Doctorate from the Loyola University in New Orleans College of Law, where he graduated with honors. And in 2010, he earned his Master's of Law with merit honors from Queen Mary University in London, with a specialization in antitrust law. He is fluent in English and Spanish and currently learning French. He brings just a wealth of knowledge to the table on the kind of catastrophic injury cases that are so often talked about on these webinars. So we're really excited to have him. His partner in crime today is going to be Dr. Travis Snyder. Dr. Snyder is a 2009 Touro University of Nevada Osteopathic Medical School graduate and current assistant adjunct professor of radiology and neuroradiology at Touro. He completed his radiology residence at McLaren Macomb, Michigan State in Michigan, and has a neuroradiology fellowship at the University of Miami, and then returned to Las Vegas to practice at SimonMed Imaging in Las Vegas. He has a special interest in teaching rotating medical students, lecturing and research on advanced imaging techniques for traumatic brain injury and carbon monoxide poisoning cases. So I know that is a mouthful and a laundry list of accomplishments and achievements for both these gentlemen. So with that, Hugo, we're going to turn the presentation over to you and let us get started.
Thank you, Kyle. So this presentation really came out of the idea and an understanding that while we do work on a lot of traumatic brain injury cases, I mean, I worked with Kyle and lots of them and Dr. Snyder, the majority of cases that we see in practice are not the big catastrophic traumatic brain injury cases. It's going to be the spinal injury cases that are the bread and butter of most firms. So with the idea and the understanding that an image is worth 1,000 words, the best way to prosecute these cases are with image findings. So that is why we decided to get something together with Dr. Snyder, bring in somebody who's very well versed on protocols, on imaging, and how to really build your case when you don't have a traumatic brain injury, you have your regular neck and back injury. And also part of this is also maybe how to identify a potential traumatic brain injury case, and whether you want to work it yourself or you want to find somebody else to work it. It's also a great tool to have in your toolkit. So Dr. Snyder, I'll let you begin.
Great. Well, thanks everyone. And thanks to Hugo and Kyle and Ginger and everyone else. And it's great to see so many people here, despite, I guess, all the snow and freezing everywhere. So yes, as Hugo said, well, hopefully this will be a educational lecture for everyone. And the title of this is actually, let me share my screen here before I get too far into this. So hopefully you guys can all see that there. So the title of this is Beyond Fractures, Imaging of Acute Spinal Trauma, Including Whiplash. And the reason, as Hugo was saying, that we chose this was because, fractures are not really debated. And, I was originally going to, make a lecture on just the types of spinal fractures, but the fractures are not really typically in contention. And then there's lots of people that have spine injuries and back injuries do not have fractures. And so this is kind of the area that I think would be kind of most beneficial to talk about. So in that case, we will get started here. So this is kind of the outline of the lecture. So first, briefly talk about MRI protocols. And then when to image. This comes up a lot, and there's some sort of interesting caveats in this that we'll discuss. And then we'll talk about the craniocervical junction and whiplash, because whiplash, I think, is something that I see in my clinical practice or in talking with physicians, that sometimes the patients may have a neck injury, but it may not be known that it's a whiplash type injury. And there's a different sort of way to work that up. And also there's a different prognosis. The prognosis for whiplash injury is actually fairly poor, as we'll see. And then we'll do some disc pathology, just a little bit on nomenclature, because sometimes radiology reports are difficult to understand. So we'll try to touch on that a little bit and the significance of disc pathology. And then most importantly, probably talk about the acute findings for disc pathology. And how do you differentiate acute disc pathology from degenerative changes? And sometimes it's challenging, and sometimes you have to hedge. And a lot of times The clinical correlation is going to be the key to these, but there are imaging features which will suggest acuity, and sometimes you can come down very hard that this is from acute injury. Annular tears, also called annular fissures, we'll discuss those, the significance of that. And then alignment, which is something I think that is kind of underlooked at in some of these cases, and then some surgical complications for trauma. So it's a lot to cover, but hopefully we'll get through this and not run too over time. But I'm happy to stay as long as we need. So I guess we'll talk about the optimal MRI spine protocol. So the 3 Tesla magnet is really the ideal, and you can think of it like a better camera lens. So there's 1.5, there's 0.6, there's even 0.3, which is kind of the lowest. And sometimes with claustrophobia, you have to scan at the lower level at those lower magnets. But all things being equal, 3 Tesla magnet, would be ideal. And there's different types of sequences in MRI, T1, T2, and other ones. But a STIR is a T2 sequence, and T2 means water. So think of H2O, T2. So a STIR is a water sequence with a fat saturation pulse. And sometimes on MRI, you can get water and fat sort of confused. But STIR is really the best image for acute trauma because you can show the annular fissures, annular tears very well. You can show the acute disc pathology, and also ligament injury. And so if you're doing a spine protocol without STIR, it's really hurting the patients. You're going to miss a lot of things that could explain symptoms. Gradient echo is a sort of a type of cervical spine axial view that we do at SimonMed, and it can add some value. Not every place does this. And then this alar ligament protocol, which I'll talk about as well when we get to the whiplash part. So here's just very briefly, sagittal T1. So this is a side view of the lumbar spine, and T1 looks like this, and the water is dark, the spinal canal. This is the vertebral bodies and the cord and then the nerve roots. And on T2, the cerebral spinal fluid is bright. So that's how you know it's a T2. So this is a T2. And then there's axial, which is slices down through the MRI. And this is some of the anatomy showing like the nerves coming out in the spinal canal, the facets, and then the discs are here and the vertebral bodies are here. So one of the things, this is an axial image, T2, through the level of the disc. This is the neural frame, and this is where the nerves come out. And so the value of gradient echo imaging, this is a gradient echo sequence on the right here. And not every place does this, but it does have some value. For example, in this case, you can see there's a bulge on the normal T2, but then the gradient echo actually shows there's some increased signal consistent with a tear or fissure in the disc centrally. And so that is the value in this case. And also sometimes you can show the neural frame better. But overall, the image is a little more blurry. So the T2s are typically the best diagnostic images, but this, in some cases, you can use it. So the gradient echo is also best to see hemorrhages in the cord. So this is the cord here in this central area here. This is the CSF surrounding it. And if you have hemorrhages in the cord, you'll see little black dots in the cord. It's not very common in trauma, but it's a very poor prognostic sign. So, we always look for it. Cord contusions are somewhat unusual. Most of the time they have fractures, but if they have a cord contusion or any injury to the cord, that's a poor prognostic sign, and they often have pretty significant deficits. So gradient echo imaging, and so here's the STIR. Here's a STIR imaging, so that shows the nice images here showing the vertebral bodies L1, L2, L3, and so forth, and you get a nice look at the soft tissues. This is normal. This is just normal showing how the STIR looks. This is the sequence. The STIR is for the ligament injury, and also the best for acute disc pathology, and also signal in the cord. Not so much hemorrhages, but contusions in the cord look different than hemorrhages. So STIR is one that we do at all our centers. So when to image. And this is spend a little time on this slide because this is kind of an important. You want to image as close to the trauma as possible. And we talked about in traumatic brain injury, the last seminar we had about when to image, and that's also true for this. But you want to image as close to this as possible because ligament injury and imaging of acute disc pathology will decrease over time. So if you have, and I'll show some cases, but if you have an acute ligament injury, it will actually heal up pretty fast. And if you image them, 3 months or 6 months after the trauma, it may not be there. And if you image them, a year after the trauma, or even 2 years or 3 years, it's impossible to see it. Acute ligament injury. And so one thing that is not really, I don't think, well known is that 6-month follow-up scans can actually add value to determining, in opinion, if it is related to a trauma or acute injury. So what happens is, you have the acute injury and you can have acute disc pathology, but then when you image them 6 months later, you can see that sometimes the disc will decrease in size. And it's very unusual to see degenerative discs decrease in size. I mean, maybe it could happen, but if you see a disc decrease in size, then that shows that it could be from the trauma. And in the same sense, if you have an increase in size, so it shows there's initial injury, then the annulus was weakened of the disc from the trauma, and then following that, then there were accelerated degenerative changes, or the injury increased and the disc got bigger. So generally, degenerative changes stay very similar over time. If you image someone 10 years, image someone at 40 and image someone at 50, you're going to see some degenerative changes that will develop. But generally, degenerative changes will progress, fairly slowly, as a usual rule. And so trauma will induce accelerated degenerative changes. So someone that has an injury they'll have increased degenerative changes at those levels which are injured, and occasionally even above and below. So, and I think we said this. So any questions so far, and anything that we've been discussing?
Dr. Snyder, I have a question. So let's say I have my client who comes in, he's had a car wreck injury a few days before. We sent him to get the MRI. How can we tell whether the herniation, the bulge, is caused from acute trauma or is pre-existing from before the accident?
Right. So, so if you have a prior imaging, is of course always valuable, but without that, there are findings for acute disc pathology, which we'll probably discuss, but it includes, edema in the disc, peridiscal edema. And then, so that those are sort of the main findings, and also unusual disc herniations. For example, just yesterday I had a case of an 18-year-old who had, very prominent disc herniation, and it didn't have necessarily the acute features, but not all disc herniations that are acute have to have that. It's more specific than sensitive. So if you have a young patient that has very unusual disc herniations at unusual levels, then you can suggest that those are trauma. And also lack of degenerative end plate changes, lack of osteophytes. Those are all things. So there's some kind of very solid rules, and then there's some kind of gray rules, and then a lot of it depends on the case.
Is there an established timeline as to when it's too late to image for acute findings?
I'm not sure if there's established, but I would say, after 3 or 6 months, that the ligament injuries are probably not going to be there in most cases. And the acute, it's not really clear when the acute the changes from the acute disc herniation will resolve, but oftentimes we'll see changes in those acute disc herniations. And if we see changes, then that suggests either healing or progressive degenerative changes from the trauma. And so as far as the exact timelines, I'm not sure the literature has like, black and white cutoff points. But if you image someone significantly from the trauma, then it's, you can still describe the stuff there. And then the clinicians will correlate and say, there's a big disc bulge at, L4-5, and they have radiculopathy that comes from there. So therefore it is, that's likely where that was from the trauma. But from imaging, you can support them, but you can't say that based on the imaging, it was from trauma, if that makes sense.
Thank you.
Doc, we did have just a couple of questions real quick. We had somebody ask, if the MRI shows a lot of herniations, is it more likely that it's chronic?
Well, that's a interesting question, and it would it would depend somewhat on the age of the patient. I mean, we would expect someone who is, 70 to, have disc bulges at probably most levels. And it would depend on the morphology of the disc herniation. If you have a young patient that has a lot of multi-level disc pathology, then it would certainly be, sometimes the way I'll dictate it, I'll say the changes are advanced for age and in the proper clinical setting, in part consistent with the patient's history of trauma. That's one way. Now, that being said, it is unusual to see, for example, I don't know that I've seen 5 acute disc herniations. So, I mean, most of the time it's one level, maybe 2 levels. So, it's pretty unusual to see diffuse disc herniations unless they have, a pretty, significant fractures or it was a very severe trauma. If that answers the question.
Yeah, no, that's good. The next questions are more centered around whiplash. So someone asked, why does the pain from whiplash sometimes occur a day or 2 after a collision?
Yeah, well, that's very well known at how you have the collision and then the patient's a little banged up and they're shaken up, and then they go home and say just tough this out and sleep it off, and they wake up and they can barely move their neck. As far as the pathophysiology behind that, I think it has to do with some of the healing changes that are occurring or the inflammation that's occurring. But yeah, I'm not sure the exact pathophysiology, but that's definitely a known, a very well known phenomena.
And does whiplash get worse as it relates to age? Is it worse in older patients versus younger patients?
Yeah, so similar to traumatic brain injury, I think last time we were talking how patients that have traumatic brain injury who are older, that's a very key part of the prognosis. Older patients do worse for traumatic brain injury, and it's similar with the spine for the same regions. If you put a 20-year-old in a high-speed MVC, they could do bad, but they may do better than if you put a 60 or 70-year-old. So the prognosis is worse with older patients.
Gotcha. Okay. Well, you knocked out all the questions.
All right. So let's move forward here. So this is the value of the STIR imaging here. So this is a T2. This is a patient that had a pretty significant trauma, and the T2 looks, you would call this almost normal. But then the STIR shows this diffuse posterior ligamentous injury. The arrows are pointing to edema, which is from trauma, all in the posterior soft tissues and by the ligamentum, the nuchal ligament and intraspinous ligament. I'll show some of that anatomy. But this is a severe ligamentous injury, which without the STIR would be almost totally missed. You might be able to make a call on it, but that's the value of the STIR imaging. So here's another case. This is a young patient. You can tell by the disc. This was a pediatric patient. I think there's actually an end plate fracture here, but there's edema on the STIR at every level here. So this patient had intraspinous ligament injury at every level, and because it was so symmetric, actually, this was a case I think I was maybe an expert on this case, but because it was fairly symmetric at all these levels, that it was missed on the initial read. So you want to look for those STIR imaging in those regions where that can occur. And this is the anatomy, just showing some of where the intraspinous ligaments are and the ligamentum flavum and the spinal cord. But the intraspinous ligament is what is injured between the spinous processes. So these are the spinous processes which are normal. This is a normal case, just to show. I always try to show the normal and abnormal because if you're not used to looking at images, it doesn't really look like much. But that's the difference in this case. So that's the value of STIR again. Here's another case, which is very similar, showing the same thing, the intraspinous ligament injuries. There's posterior edema here, probably in the back, and here's more focal edema. And there's some edema anterior to the vertebral bodies here. So there's the anterior longitudinal ligament runs down here in front of the ligaments. There's a posterior longitudinal ligament, and maybe this shows. Well, it doesn't show those, I guess, but it shows some of the other ligament anatomy here. But so this is a case of ligament injury. And if you did a CT on this person, it would just be normal, be read as normal. So you have to do the MRI to see the ligamentous injury. CT is non-diagnostic. Maybe we should have talked about this in the beginning, but CT is non-diagnostic for acute disc herniations and for ligament injury. I mean, unless there's like some severe displacement of the vertebral bodies or malalignment, but it's really only good for fracture. It's just, you just can't diagnose it. And they do it all in emergency rooms. A lot of times they'll do it all the time because fractures are life-threatening. So if you have fractures, so if a patient has a whiplash or a neck injury, they go to the ER, they won't get the MRI, they'll get the CT because that's life-threatening. All this stuff here that we're showing is not life-threatening, and patient's not going to die from a ligamentous injury. They're not going to, but this can result in significant morbidity and perhaps disability, and it won't be diagnosed without the MRI. So. All right, here's another case, not to belittle the value of STIR or to build it up too much, but here's another case, a very focal injuries between the spinous processes here. This is the posterior, this is the anterior, this is another side view, STIR imaging showing the edema in the disc adjacent to this spinous process, and there's increased signal in the spinous process. So there was either a contusion to that spinous process or a fracture, and this is showing those ligaments which were injured in that. And the clinicians, if they get this report, they know how to test for these ligament injuries. They'll have them do, and I don't know exactly all the physical exams or what they do, but they can confirm this clinically with tenderness, with different tests that they can do to support the imaging. Or actually, I should say the imaging supports them. So these are some cases. I just included this because it's very subtle. These are some of the most, I tried to include in this presentation some very subtle cases because those are the ones that are the most difficult to kind of diagnose. So here's a cervical sagittal view, and there's the very subtle increased signal on the STIR imaging in the intraspinous ligament. And the same here in the lumbar spine at L4-5. There's some subtle increased signal diffusely here. And you want to be careful on this because sometimes vessels can course through. There's vessels in the back of the spine, in the cervical and lumbar. And the vessels, sometimes I've seen people occasionally overcall ligament injury when they're just unusual prominent vessels in those regions. So if it looks linear, then it's probably just a vessel. So you want to look for that. So just for completeness, I know this lecture is not on fractures, but I just wanted to show what one looks like since we're talking about spine injury. And this is the STIR image again, showing the edema involving the superior end plate. This is the disc, and this is the vertebral body, anterior, posterior, and that's the spinal cord and the CSF. And so there is the edema there, and then the T1 image is good to show these fractures. So there is the end plate fracture. This is an acute fracture because there's edema around it. Now, if you have a lot of times we'll see patients, for example, there's some height loss here. So you might say, well, isn't that a fracture too? But there's no edema. So maybe it's an old fracture, maybe it's a Schmerl's node or something, but this is certainly not related to the recent trauma where this one, it certainly is. So here's the last example I'll show of a fracture, and I just showed this hangman's fracture here. That in this case this is an X-ray, so lateral X-ray shows the fracture line there. And this is what fractures look like on CT. CT is best to diagnose fractures, although MRI will show the edema. This is a STIR, showing the edema involving the pedicle here. And this is called a hangman's fracture. And actually, Hugo and I had an interesting case with this. I don't know if Hugo, if you want to comment on your experience with these fractures or how from your perspective you kind of worked these up.
Yeah, so in our case, it was actually a traumatic brain injury case where it was some debate whether the client lost or didn't lose consciousness, and they try to minimize the impact. However, Dr. Snyder was able to determine from the imaging that it was called a hangman's fracture. And based on that, we were to get clinical correlation of the force of impact that would cause the bone to actually break and throw the client's head forwards and backwards, and correlate that with the traumatic brain injury. So one thing you always want to look at when you're doing these cases is if you have a hangman's fracture, it shows a high level of impact in a collision. And it's really good because a lot of times defense lawyers or insurance companies will try to say it's a minimal injury, it didn't have much speed. Well, it had enough force and speed to break her neck. And that is very powerful in front of a jury.
Yeah. There actually seems to be a little bit of debate going on. I think, Doc, if you could take just a second and talk about bulges versus herniations. That seems to be what you get a lot of you see a lot on reports and impressions on MRI findings, and maybe in your opinion, what differentiates the two in severity?
Yeah. In fact, I think we have a slide coming up on that. Yeah, we'll spend some time on that, because I agree. I think that is a good point, that we need to kind of spend time on that, because the nomenclature can be kind of confusing. And also, we were talking about this earlier, is that neuroradiologists generally will always call the big stuff the same, but some of the nomenclature, how descriptions are used for disc pathology, actually varies quite a bit. I mean, they won't differentiate on the size of it, but they may, different radiologists may call it, especially if they're not neuroradiologists, may describe it differently.
Understood. Somebody asked the question, if there's no edema, how can you prove the MRI finding is due to trauma?
Well, if there's no edema then in the bone, then it, from a fracture, then the fracture is not due to the trauma, or an acute trauma. Now, I mean, sometimes we'll get a case where a patient is imaged 6 months from the trauma, and it says 6 months, and then you see some fractures, and there's really not much edema. You could still say that given, I mean, it shouldn't be a debate, I mean, in the clinical record, that the patient had a fracture. So, but yeah, it's tough to put that in the report. You could just say that consistent with the described history of fractures or something like that. And as far as the disc edema, that's the morphology of an acute disc herniation doesn't necessarily have to have, or a more acute disc herniation, or post-traumatic aggravation is a term that's used a lot. So there's pre-existing degenerative changes, and there's a post-traumatic aggravation. And sometimes there's no imaging findings for that unless you have a prior, and it becomes a clinical diagnosis. There's lots of disc pathology that is indeterminate by imaging, but it's important to say it's indeterminate. It's you can't just say that it's definitely just degenerative, unless it's just like an osteophyte or something. But it's good to differentiate. But also the morphology of the disc herniation can help as well.
Got it.
Okay, so let's we'll get through this fairly quickly here. More images on STIR. There's an anterior longitudinal ligament here again. This is a contusion. So this is the vertebral body contusion. There's no fracture here, but this is not like a end plate degenerative change where it's just at the end plate. This is involving the vertebral body. So this is a contusion, a vertebral body contusion, which means there was probably a significant force involved. Another thing to look at on the sturmagene is this facet effusion. So facet effusions, they can be degenerative, but they could also be related to a facet injury, especially if there is edema in the soft tissue surrounding, or edema involving the facet. Patients will have a facet capsule injury, and it can look very similar to facet arthritis. So, the way that I'll dictate some of these, if there's an older patient where there's a facet edema and perifacet edema and edema in the facet and a facet effusion, I'll say this could be consistent with facet arthritis or ligament injury, and clinical correlation is suggested. Or I mean, I meant to say a facet injury. So it could be from both. So, okay, well, we're going to do, I guess we'll get to the disc pathology, but we're going to kind of start at the top of the skull and kind of go down. So this is the atlanto-occipital joint. And this is C1 attaching to the occiput here. And this was a case, the reason I included some segments on this is because this is something that is not often, it's not something that's maybe looked at very carefully by radiologists as much. And so this patient had a little bit of separation there, and there's some edema there. And so that's a pretty significant injury. And if it's a dislocation, this is not a dislocation, but these are have a pretty high morbidity when you have these sorts of atlanto-occipital injuries. So here's the same case where there is a separation, and then at the time of the trauma, so this is an MRI scan, this is a CT showing the separation. At the time of the trauma, there was edema in the joint, and there was diffuse edema in the posteriorly, and then 1 month after the scan, it resolved. So this is why if you image it here, you would say the patient is fine, but here it shows the injury, here it shows the edema. So that was an atlanto-occipital injury, which is a pretty significant injury. And here's the, so this patient had bilaterals. This is the right side. And then this is the left side. And the left side had the same thing. So the left side had the same finding. So that was an interesting case. This is another patient with a severe ligamentous injury on the sturmagene. We've already seen a lot of these already. And this is just kind of showing that same patient, the bilateral injury with the right and the left, kind of how to sort of present this as because in this particular case, there was a debate and argument whether there was any injury there. So I was trying to show very clearly that it was 100% related to the trauma. And then this is the zoomed up image showing the same thing, the resolved on follow-up. And then this is the same patient who had a severe ligament injury here. Here's the anatomy again, and then it resolved 1 month. So these are ligament injuries. It can resolve fairly fast, especially in young patients. And this is a right facet effusion. So the patient had a trauma, and then they had this effusion adjacent to the facet, and that can be, it could be related. And so that this is where the facet capsule is. So it's kind of showing some of the anatomy there, where the facet injuries can occur, and it's very difficult to differentiate these from facet arthritis. But you can mention both, and then the presence of new symptoms there. This is on, say, the right side, and the clinician is pushing there and doing the clinical exam, and they find that is where they're having new symptoms. Then that becomes an imaging finding supportive of trauma. All right, so now we'll talk about whiplash. So what is whiplash? And I think we maybe discussed a little bit, but it's a hyperextension and hyperflexion of the cervical spine. So it's where the head is jerked backwards and forward. And by far the most common cause of this is car accidents, because that's when people, stop and move fast. I have seen some of these, caused by other things, from assaults or from different types of trauma. But the important thing about whiplash is it has a very poor prognosis. 50% of patients suffer, persistent symptoms 1 year post-injury, and there are high rates of resultant disability. And this was an article that talks about this, and this would be a good article because it's a very authoritative article. It's kind of a white paper by the society of all these people that study whiplash. So it's not something that's going to be, it's not a fringe publication. This is really the article that describes a lot of this stuff. So it's a pretty good read. And then, are we missing brain injury? As Hugo was saying, when you have spine fractures, you're more likely, and especially with facial fractures, there's a very high rate of brain injury with facial fractures that increases as you go deeper into the different pillars of the facial bones. And so this is an article. This is a recent article, 2020, which talked about this, and they found using fMRI actually that there was a association with brain findings from a neck injury, which was quite interesting. A lot of times the clinicians, I work with one here in town quite a bit on these, and he says a lot of these patients have headaches. That's from what he said, they get a lot of headaches that are cervical generated headaches, but it from the brain. And so that's one thing we're doing with our research. We're doing research on that. And some findings haven't found much, but there are studies that have showed perfusion and white matter injuries in these whiplash associated disorders. So,
before we go in, can we go back to the other slide, the one before that? Yeah, that one right there, because I think it's really important. When you look at the imaging right there, not the image itself, you can see the head going backwards and forwards. Now, from the brain injury perspective, can you describe the coup contra coup injury, and is that consistent with the whiplash injury?
Yeah, that's a good point. So yeah, the coup contra coup is when the force comes through here, and you get an injury to the frontal lobe, and then the back of the brain hits the back of the skull, and you get an injury here. So if you draw a line, it doesn't have to be frontal to posterior. It can be left to right or diagonal, but wherever the force vector is, you can get a coup contra coup. And when you have these sorts of brain, I have seen one of the questions I sometimes get asked, in depositions or other places is, can the patient have a brain injury without hitting their head? And the answer, because of this shearing forces, the brain is moving so fast. I mean, a lot of times these patients will hit the back of their head seat, and sometimes they won't know it, and they won't even, they'll be so dazed they won't know if they hit their head or not. But you certainly can from these forces, and these rotational forces which are applied to the brain, will cause primarily shearing type injuries that you can see.
So I guess the practice point for us lawyers here is whenever we get an accident and we can find a whiplash type injury, and we want to maybe build the case as something more, we could consider a brain injury and start maybe doing a workup in that case.
Yeah, and not all whiplash patients will have brain injuries, but I think if they're having symptoms that are, you know, that are from that, then yeah, you wouldn't want to miss that.
Correct. I'm often called on by young lawyers say, listen, I have this case, a back case, not worth much. I don't know what to do. They have huge coverage. It seems like a minimal injury. It's just a whiplash case. And that's when I tell them, listen, look for the symptoms. You might have a brain injury case. You can either refer it out or work it up yourself, but it's something to always be aware of, that a whiplash injury could lead to a traumatic brain injury.
Hugo, you got a question here. Somebody says defense is always saying everything is degenerative. You know, that's always the argument. You know, how do you refute that argument when there is no edema?
So as a lawyer or as a doctor?
Well, it might be good for Dr. Snyder to opine, but then you can talk about, you know, I mean, that's typically the defense that they see. Hey, everything's degenerative. You know, nothing was from the trauma.
So I'll let Dr. Snyder take the first lead. I mean, I've played a doctor, but only at a bar.
Yeah, well, so yeah, I mean, there's other findings though of trauma besides disc injury too. I mean, one thing we'll talk about here is malalignment, and malalignment is, I think, an important part of traumatic spine injury that we'll show cases of, and also just because there's no edema in the disc doesn't mean that the disc was not injured. It's a sensitive finding, a fairly specific finding, you know, for that, where it would be consistent with it. But in the absence of it, it still could be a traumatic disc herniation or post-traumatic aggravation. And a lot of that requires clinical correlation. But the radiologist can look at the other findings that are there. If there's a facet injury, if there's ligament injury, if there's other things, and also the changes over prior. So if you have a large disc herniation, and then you get the follow-up and it gets better or it gets worse, that's something where we can add. But a lot of these spine cases require the radiologist and the clinicians to kind of work together on it. It's really especially in a case like the questioner was describing, it requires kind of a team effort.
Yeah. Hugo, I mean, I guess what is your perception of the defense that's always thrown up of, hey, everything is degenerative?
Well, I mean, I love the defense arguments because they really kind of make your head spin sometimes. It normally starts that there is no injury, but if there is one, it was there before. From the legal perspective, you always want to look at, well, the prior complaints. Prior medical records are great. I mean, if this person doesn't have any prior complaints of neck pain, back pain, can work without a problem, and now suddenly after the incident, they have these complaints, it just sort of makes sense to a jury that this is what caused it. Taking it to what the actual case law says, for example, in Louisiana, we have the Housley presumption, and other states have very similar presumptions that say, if you're in generally good health before the accident and subsequent to the incident, you have these symptoms, it is presumed that the symptoms were caused by the accident. And the third part of that kind of argument I would use is go to your physician and say, doctor, how do you diagnose patients? By history? Yes. Okay, look at the history. Then what is more probable than not when you don't have prior complaints of this and you have an incident and now you have this? So going back to that hangman's fracture case that Dr. Snyder and I had, our client had a prior suicide attempt. And the defense tried to capture that and say, listen, suicide, she tried to hang herself, hangman's fracture, it's old. Well, you have calcification around the broken fracture, which you don't have on an acute fracture. That is why you want to get the imaging done early. Had we waited a year to get the imaging done and we had calcification, the argument might have had legs. Because we got the imaging done so quickly, they weren't able to make that argument.
Yeah, and I might have agreed with them. I would have said it's indeterminate by imaging. There's healing there. It's a healed fracture that's indeterminate. And to answer the questioner too, radiologists can also give some insights regarding the disc pathology. Is it an unusual level? Is it advanced for age? are there osteophytes or degenerative or chronic degenerative end plate changes? And if we put all that in the report, then it could support that even if there's not edema in the disc, that there was a aggravation of that level. Okay, so I think, yeah. So let's do the anatomy of whiplash here. So this is this is kind of an axial view of the C1, and this is where the skull sits right here. So whiplash is involving the skull base, and these are the ligaments here. There's really three that are kind of important. There's the transverse ligament, which holds the top of C2, the dens, in place. There's the alar ligament, which comes off and attaches to the condyle here, to the clivus, and then there's the apical ligament. So these are the ligaments. Here's a side view kind of showing the same thing, and then there's a temporal membrane which comes back and kind of runs with the anterior to the spinal cord and the posterior longitudinal ligament here, and kind of blend. So all these structures here, these are all structures that can be imaged injured and imaged in whiplash. So here's a case. This is a case that was kind of pre-trauma, and a very subtle case. But this is the temporal membrane coming here, and it looks intact. And then the post-trauma, there's a little bit of waviness here. So when ligaments kind of retract a little, or membranes, then it becomes a little wavy. So there's a little gap here. So fairly subtle, but this was a subtle case of a whiplash injury. And also, in the region here that I'm showing here, these 4 black dots here, some are seen pretty well here, but over here there's a lot more. There's a lot more dark here. So there's probably some subtle edema here that is likely involving the apical ligament in this case. And so this is just to show the apical ligament, where that is, and then that's the temporal membrane and the apical ligament. So there's a very subtle whiplash case that was, according to the physician I talked to, the patient had a lot of symptoms from that. This is another case. So this patient, this is a temporal membrane injury. So this was a trauma was here, and then this was MRI. I think it was, I'm not sure if it was a year, but it was, it was after this, pretty significantly after the trauma, but the patient kept having symptoms, and there's a little deficit there. And I read the follow-up and, saw that, and I was like, well, that's pretty subtle. I'm not sure. And I looked back and it was there as well there. And then the patient, it was a whiplash patient with a subtle injury there. So that shows, what was imaged there in the tectoral membrane there. So this is our alar ligament protocol, and this is I developed this protocol for SimonMed. I spent many hours on this, more than I would have liked to, with the techs, and we were scanning volunteers over and over, trying to get the best image of the alar ligament. So this is our protocol. We have 2 sequences. We do this CIS is called CIS or Fiesta, depending on the vendor. So it's an axial sequence, which is a high T2 thin section. And then we do this PD non-fat sat coronal, and this is our protocol. And it's a 5-minute total scan time. And so when you put these 2 sequences together, we're able to identify ligament injuries up here that we weren't before, that you cannot without a good protocol. And there are some literature that talks about alar ligament protocols, and some of the articles say that it's actually imaging is not very sensitive, is not great for it. I mean, they say you can diagnose it and it's useful, but it's not that some of the articles say that they don't really fit very well. But I think with this sequence where we have 2 protocols that look at this area, and this is just a beautiful image showing these ligaments, showing the transverse ligament and the apical ligament, that we can pick up some of these at our centers using this. So here's an example of a normal. So this is that high resolution T2 showing the transverse ligament, showing the alar ligaments here. This is the alar ligaments here and the transverse ligament and the temporal membrane. It's very nicely seen there, much better than that other image we saw. So you can really see this very well, and that's the protocol. That patient was more or less was normal. So a couple cases of pathology. So this is the left transverse ligament. So this is what was injured here. And you can see here, this is the right one, and the right comes in here. This is axial image, and this is the dens, and this ligament comes in and it looks intact. On the left, there's a little gap here, and there's some edema here, pretty subtle, but there's some edema involving that transverse ligament. So this was a case, and this was a clinically corroborated case of a whiplash injury, which we were able to collaborate with the imaging or support with the imaging. Okay, here's another case, and this is now, it's the apical ligament, which is injured here, and this is the normal left apical one, nice thick and black ligament attaching, and then here's the right showing that signal and showing that, and this is a different slice. This is 2 slices, so that's quite helpful if we can say it's on 2 slices, because one slice someone could say, well, maybe it's artifact, or maybe it just, you just caught something there that was, but if it's on 2 slices, we can come down pretty hard and say, that there is a ligament injury, a whiplash type injury on this high resolution alar ligament protocol. Just another case is a different case. Same thing, apical ligament. This is also on the right. The left one looks pretty good, and then this is showing that gap there. And the patient's a little rotated, so it's not ideal. And this was the PD sequence where the patient was rotated. So you might say, you might say if you only had this, that there was suggestion, but to correlate clinically. But then we did our second image, our second sequence, and there you can see it really well. So this is showing that gap there, whereas the left one looks within probably within normal limits. But this is the gap here on the right. So that was by using the double protocol, if you will, we can pick these up pretty nicely. And this is a really nice case. So one thing, I would probably recommend any patient that has a concern for a whiplash injury or a ligament tear in this region, if they're having symptoms there, to get this open mouth side bending odonto view. And this is what it looks like. So the patient just kind of bends their head this way, tech takes the image, they go this way, tech takes the image. And what you can see is that normally it should be symmetric. So this is C1, this is the dens, and just like we saw in the anatomy, and then this is kind of the normal side. So this is, it kind of lines up here pretty nice. But if you go to the left side, you can see that the lateral mass of C1 is off on the right. And it's not by much, but maybe it's 2 or 3 millimeters here. So there's some lateral subluxation on left side bending view, the left lateral mass of C1 on C2. And that by itself, you might say, well, correlate for ligamentous laxature injury is kind of the dictation. But they did an alar ligament protocol. And this shows, this is the normal one on the left, and this is the one that's torn on the right. There's probably a partial tear there, maybe even a complete tear. And so because this is not, there's nothing to hold this side back, this slides off more because this ligament is torn. So this part will slide off more. So that's kind of the mechanism of this. But alterations in these side bending views along with this can be pretty helpful. So here's an interesting case. Someone was saying, well, what if there's no edema? So this is a normal, first of all, and this is the tentorial membrane, nice, thick area. And this was a case of a history of whiplash 6 months ago. And I actually read this case last week. There's a big osteophyte here. So there's an osteophyte that's there. So why would they have an osteophyte? But there's no edema. So this is a stir. So there's no edema there, but there's a kind of an osteophyte there inferior to the clivus. So one possibility of this is that this is an avulsion injury or an injury that then calcified and became. And so this would be consistent with the history of whiplash in the appropriate setting, even if there's no edema. If that makes sense. So kind of interesting case. All right, so now Kyle will talk about the disc pathology, and hopefully we're not running too low on time here. But this is well, actually, we should. Any question on whiplash before we move on, or any comments?
Yeah, we got. Go ahead. No, I'm just gonna I'll try to get through them. We're, as usual, starting to stack up questions. Okay, the first one is, what about the long-term implications? Will someone injured with whiplash at the age of 50 start to have worse problems when they turn 60?
Well, that would depend on, I think how bad the whiplash was, what ligaments were injured. A lot of it would depend on the case. But I mean, I would just in general, and there's probably people that the best person to ask that question would be people that treat the whiplash injury, that specialize in that, the clinicians. But I mean, as a radiologist, I mean, this is the patients with whiplash do poor. This is 1 year and resultant disability. So I think if you had someone that had that type of symptoms, it would probably be fairly consistent with what is known about these injuries.
Okay. Are there whiplash injuries that cannot be detected with imaging?
Yes, and so one thing that when I dictate even this alar ligament protocol, which I said we're quite proud of, or blood, sweat, and tears over making it. If it's normal, I'll put a little caveat that says alar ligament imaging may be insensitive, and that's concordant with some of the articles too that say that that the imaging is not great, but we do the best we can with this optimal protocol. But yeah, certainly even if it's normal, the patient still could have an injury there, and that would just be a clinical diagnosis.
Understood. The next question is, how common is it for STIR images to be taken in an emergency department setting which doesn't involve a closed head injury diagnosis?
It's mostly CTs are performed in emergency rooms. So the MRI of the cervical spine may not be performed because the findings are generally not life-threatening. And so, but if it is performed, I would say most emergency rooms have STIR imaging. And maybe like 5 or 10 years, 5 years ago, that was not the case. But now I think most places do have STIR imaging. There are some centers that I see around town in different states. I mean, I read for like 10 different states. And occasionally, we'll see a prior or something from from like a center that doesn't have STIR imaging. So definitely, I would check that. I would say most ERs have it and most centers have it, but there are some that do not. And if there's a case that someone gets scanned at one of those places that don't get it, that could really limit the diagnosis.
Understood. Do all MRI machines have STIR capabilities, or does it take a special machine?
So it's not like traumatic brain injury where you have to pay the manufacturers to unlock like spectroscopy and DTI and perfusion and some of those advanced fMRI, like those advanced sequences. So it should be on every modern MRI machine has it. Now, if the one, and it may be some older ones that don't have it, but it's not something that you have to pay to the manufacturer to get. It should be included in it's just the only downside. The reason why some people don't do it is just because the time, it's just an extra, 5 minutes in the scanner, and some imaging centers just want to, get people in and out. So.
Understood. I guess that kind of feeds into this last question, and it says, how much does a T2 MRI cost to perform and have analyzed and read?
Sorry, analyze the what?
How much does it cost to perform a T2 MRI and have it analyzed and read?
An MRI spine protocol includes multiple sequences. So normally it's T1, T2, STIR, sagittals, and then axial and gradient echo. And as far as the cost, that's all over the place. I mean, it differs. I've tried to keep track of the cost, but it differs by state. It differs by insurance. It's different. Like I think the lien prices are, all over the place. So I just don't have a good estimate.
Okay.
I have a question, Kyle.
What you got?
Dr. Snyder, your alar protocol, which seems pretty cool for the whiplash injuries, is that exclusive to SimonMed? I know you mentioned that you created it.
Only at SimonMed do we have this, but this is the protocol, so anyone can do it. We're not trying to hide it, at our centers, but this is what it is. So, some places do have other alar ligament protocols, but I haven't seen any place with both of these. They'll do one or the other, and sometimes like to get we were testing this, and we tried this at 2 millimeters, and we tried this at 0.5 millimeters. We tried this at 2, and we tried this at 3. So we did all these different combinations to get the best picture. And so I have a feeling that if other places didn't put the time into it, they may not. They may have one of these, but it may not be the the optimal setting. But there's probably other places that also have pretty good protocols.
And I guess the next question sort of dovetails into that, and is there any published medical literature on your ALR protocol as to how it's different from others or better?
Yeah, that's a good question. No, we haven't published it because we would need to, it'd be a tough thing to do. We'd have to have controls and traumas and be able to we have to have some reason to publish it besides just to show that it was, very clear. So it's a good thought, but we haven't done that yet.
And my only concern is I'm thinking, if I'm the defense lawyer in me would come in and say, well, it's only Dr. Snyder's protocol. Has it ever been tested? Has it been peer reviewed? Does it withstand a Dover challenge?
Oh yeah, I definitely think it would, because this alar ligament protocol is not something that I invented. I mean, there's protocol. The alar ligament protocol is there are other centers that do it. They just do like, one of these or the others. So this is not like it's just a tweaking of the existing sequences. So there's nothing new. There's nothing, it's just doing more imaging of already existing sequences focused on a certain region. So yeah, it definitely would survive a Daubert. And whether people would, we have other comments on it that I guess we would just say that we've, used it, and it's been effective in our experience. So
just so we're clear for, a lot of us who don't deal with a lot of medicine, is the protocol is just a series of images, and the way you take the image and you do more images. It's not a new technology.
Oh, right. Yeah. This is not anything invented. The alar ligament protocol is just the best way to look at this region. And so we've just basically done it twice with different sequences, and we've tweaked the sequences using these technical MRI parameters to give like the best image. So it's not an invention or anything that's really that exciting. So,
all right, thank you.
Yeah, thanks. That's a good good point there. All right, so disc pathology and nomenclature, a little bit about that. So, disc bulges, this is an axial view of the disc, and this is the side view, and this is how they're named. So bulging is when the disc is diffusely bulging like that. So it goes all around the disc, or 50% of the disc. Protrusion is when the disc herniation comes out and becomes more focal. And then extrusions have a narrow neck than a body, and extrusions can go above and below. And in terms of what is more likely to be traumatic, you can draw the arrow this way. So disc bulges are probably more likely to be degenerative, although they can be traumatic. But all things being equal, depending on the features, just a disc bulge itself, it'd be tough to call that more likely than not traumatic based on imaging, unless there were some other features such as edema or what. Protrusions and extrusions, these can be degenerative as well, but extrusions, as we'll discuss, are very unusual in asymptomatic people. And so, these could be traumatic, and it's also possible they could be degenerative. This is how they look. And the location of these, this is how you describe it. So you can say the central, and this is the paracentral or paramedium, foraminal, and extraforaminal. So what a neuroradiologist does is they take this and they add it to this, and that's what you see in your report. So, the framework is not too complex overall. So extrusions and trauma, this is what we're talking about. So this is an article, these are two articles that talk about the prevalence of annular tears or fissures and disc herniations in MRIs of cervical spine. This is of the lumbar spine. So in patients that were normal, so these are patients, no back pain, just there for the study only, for the academic purpose of the study, and only 3% had an extrusion, and only 1% in the lumbar spine had an extrusion. So therefore, this is important, we're talking about acute imaging, because if you have a patient that comes in and they have an extrusion at a level in the cervical lumbar spine, and they have new symptoms that are related to that level, then it would follow that likely there was post-traumatic aggravation, or maybe even the whole extrusion was caused by the trauma, because it's just so unusual to see those in asymptomatic populations. Now, if the patient has pre-existing back pain or something, or had some other traumas, then complicates the picture. But I think this is an important point regarding extrusions. I really make sure that if there is extrusion, I try to put it in the report. I look to see if there are extrusions. I don't just kind of fly through it and call everything disc bulges. So because of this kind of important fact. And this is kind of what they look like. They come out and they go up and down. And I've seen people, other experts or different places where they just call everything disc osteophyte complexes. And then I'll put this right next to it and show the patient's image right next to it and say, this is clearly an extrusion. There's no question that this is most accurately defined as an extrusion. And I don't know why, this other person called it, disc osteophyte complex. So here's some examples of extrusion. So this is how they come out, and this is what they look. And this is a patient that had, an extrusion here, a large extrusion. There's no osteophytes here. It's a pretty big extrusion. Here's another one with an annular tear, and there probably is some edema in the disc here as well. So that's all kind of fits with. And this patient had a pretty significant trauma. I think this was a well, I don't want to say the wrong thing, but I think this may have been like a tractor trailer. It was a pretty bad trauma from what I recall. Here's another one, 32-year-old female, recent trauma. I mean, you can see there's really not many degenerative changes, maybe a disc, probably a disc herniation there, or disc bulge. And then this is the extrusion. So the extrusion comes up and goes way up, and there's edema in it. There's an annular tear. So this is an extrusion, and we're measuring the spinal stenosis and the mass effect on the cord, ventral cord flattening, and all that. And this was an annular tear down here at this level. So that's an example of extrusions with more acute features. So this is really the kind of the meat of what I think we were discussing, or what a lot of the questions about were from our audience here. What are acute features of disc pathology? And there's how these are interpreted. There is I'm not going to say that it's a black and white issue. There is some gray area in here in terms of how these are. What is the most sensitivity and specificity of all these findings. So really putting it together is how you can put them all together. So acute features, one would be lack of degenerative changes, end plate changes, disc desiccation, or osteophytes. That would be kind of I would say it's a mildly helpful feature. Increased signal in the intervertebral disc. This is the disc edema, also known. So that would be a sign. Peridiscal edema, where there's inflammation around the disc, so not in the disc, but adjacent to the disc. That's been described. And then annular tears, they can be degenerative or they can be post-traumatic. Bright on sturmagene may suggest some edema, vertically orientated. So they're not going, the disc fibers are kind of like circles. And if you have a vertically orientated, then it means that the tear is going against the fibers. And so that would be, a possible feature that should be, I think, mentioned in the report. Unusual features or levels of disc herniation. How does it look? Associated findings: ligament injury, ligament edema, fractures, contusions. So if you have all these at the same level of a disc, it might push you to call a disc herniation more likely traumatic, than not. If you have other features that are there, if you're kind of on the fence about it. Disc pathology in young patients. This is a big one that I've spent quite a lot of time looking at some of these normal articles on young patients to see, what are the degenerative changes that are expected. And if you have young patients that have a lot of unusual disc pathology, I think that's helpful to state that. And we talked about that. So any questions on this?
Not at this time.
All right, great. So let's show some of these cases. So yeah, this is there's a L5S1. This is probably like a 6 millimeter disc herniation. And by the way, I should define disc herniation. Disc herniation is kind of a wastebasket term, but it means, generally it's considered to mean protrusions or extrusions. It's disc bulges. Some people use the term disc bulge in herniations a little bit interchangeably, but mostly herniations are sort of beyond, a little bit more focal than a disc bulge. So it's a generic term, and it's not really, the terminology of a herniation is not really well defined, or at least talked about by, it's used differently by different people. But anyway, so this is a probably a large protrusion here. There's annular tear and there's edema, and then on the sturmagene there's some ligament injury at that same level. And you can see that this part of the disc, which is herniated, is bright on the stir. So this would be edema that's right in the disc herniation. So this would be consistent with a more recent disc herniation, and is therefore consistent with the patient's history of trauma in the appropriate setting. That's how I would dictate it. And if you're doing expert reports, then you have more information, and it gets a little more complex. So you could just maybe talk about it a little differently. But just from the clinical report, that would be probably a pretty good way to describe it, in my opinion. So where does this come from? This backing up of the imaging acute disc pathology. I mean, we can't just say that the literature says that, because of course it always gets questioned, especially in cases that are in litigation. You have to back everything up. You can't just be having opinions without without a basis. So this is the article, and this is a very, very, very good article. It's just like that article on Whiplash. This is by the combined societies of North American Society and Spine Radiology and all these people. So this is called a white paper, and Nomenclature 2.0 is the name of it. And this is a very, I think, definitive source of all these information of what is the current state of the literature by an authoritative group. This is not a fringe article by any means. And so this is, I've highlighted kind of, maybe you guys are reading this as we're talking here, but this is where it talks about these findings. So this is where these opinions come from this article, if they're questioned.
Doctor, we did have a question pop up about the previous slide when you're talking about degenerative stuff. He says, is there a commonly known age wherein degenerative changes begin? For example, will you begin seeing degenerative changes at someone 20 and older?
Yeah, so that's a great question. So generally, in pediatrics, you will not see degenerative changes at all. And then if someone who is 20 in the 20s, you generally will not see very much, if any. I mean, maybe there'll be like a small broad disc bulge in like a 25-year-old. But some of it depends too on occupation. People that are in sports or like hard manual labor, you do see that those they tend to have worse spines. But 30, around the 30s, and then I think by age 40, most people would have. You could have normal spines at 40, but most people will have some kind of bulge or some mild degenerative end plate changes or facet hypertrophy at 40. And then 50s, 60s, and of course 70s, and then when you get up to 80s, I mean the spines are just they're just a mess, and it's really tough in these people that are 80 that come in with acute spine trauma. I mean, similar to TBI brains. I mean, sometimes it can be, there are findings you can talk about, but people that are very older people, when you're from a perspective of acute trauma, it can be tough because there's just so many severe degenerative changes that to tease out an acute injury sometimes can be challenging. But yeah, great question. So here's another case. This is the normal disc signal. There's a big disc bulge here, and there's no degenerative changes at all at this level. So that would be consistent with acute appearing disc herniation. Here's another patient. This is a pretty young female, and there's a disc herniation here, which you can see some edema. That there's no degenerative disc signal or degenerative end plate changes or osteophytes, and there's that annular tear there. So that would be consistent with that. Here's a patient who was assaulted, and this is a terrible large disc extrusion there. Coming out of the disc, and I talked to this guy was assaulted, and then he had trouble moving his feet or felt radicular symptoms in his feet immediately following the assault, and this abuts the nerve roots. So that was an example of a acute disc pathology. So some other things that are to talk about is these acute interosseous disc herniations. So the disc bulges we've been talking about have come out the back. Generally, so far we've talked about those, but sometimes the disc herniations, acute ones, can go into the disc, and they're called Schmerl's nodes, or they're called reactive Schmerl's nodes, or acute interosseous disc herniation. This is the article that sort of talks about it in a pretty nice way. And it can cause, and whether these are end plate fractures, I mean, technically the end plate is fractured because the disc is going into it. They're not really called fractures. They're called acute interosseous disc herniations, but this is the edema. So this particular case was a trauma case, and they had, a lot of symptoms following the trauma. And they have edema here, and they have Schmerl's nodes, and they have disc herniations there. And so imaging of acute disc pathology, post-traumatic aggravation. And so this is from that same article we discussed. And so they can have brighter signal from which disc originates, and a relatively acute disc herniation can be superimposed on a pre-existing herniation, and then acute disc herniation may regress spontaneously without specific treatments. This is what we were talking about before, how the value of follow-up. So if you see, for example, this was if this was acute, taken a couple, maybe just making this up, a week after the trauma, there's edema in the disc, so it's more acute, and then you get the follow-up and it's resolved. I mean, then that's highly consistent with the history of trauma. So here's another example of a acute one. This is just showing, taking that, putting it into a slide, showing the left foramen this patient had. This is the L4-5 nerve root coming in. There's edema in this disc on the left. So that would be concerning for acute disc pathology. And here's the healing changes we were talking about. This one is kind of a subtle example, but here's the CT at the time of the trauma, remember, for life-threatening fractures. And you can actually see there is a disc bulge there that's pretty sizable, even on the CT. And then, in the MRI, it looks like it's kind of decreased in size, maybe a little bit. And then on the follow-up, then you have new osteophyte there. And this CT is very good for osteophyte. So CT, you would have seen this osteophyte if it was there. So this picture overall, you can't really make any diagnosis from any of these scans by themselves. At least I couldn't. I don't know anyone that could, but if you have them all together, you can kind of put this kind of together and talk about how this really fits the pattern that you would see in trauma. So the questioner asked, what's the rate of degenerative changes? How fast does the spine age? And these are articles that talk about it, showing that generally people are very stable over time. So I've used these before to support the opinion that changes are related to healing or injury or progressive degenerative end-plate changes. And these are, you can read those if you'd like. Annular fissure, annular tear. This is also showing this annular. So this is when there's some tearing of the disc with some signal there, and this is what it looks like. This one I would not say there's edema in the disc. I mean, it's more these annular fissures or annular tears, and this is what the histopathology is, the radial component which goes in to it. And these have pain generators, so these can cause symptoms, and we'll talk about that. This is the vertically oriented annular tear and the posterior disc here. Now, if the tears are big enough, then they're called actually a high intensity zone is the term for it. So they're right on sturmaging, and they're pretty sizable here. And the difference between high intensity zones and edema can be subtle to differentiate the two, and sometimes they may coexist. But this is a nice article that talks about how these high intensity zones cause symptoms. In fact, they said that there's a very high association between it's highly. I think the term they use is highly correlated. So these high intensity zones are highly correlated with symptoms. So just like extrusions, if the radiologist says there's a high intensity zone at a certain level, and the clinician says there's new symptoms at that level from the trauma, then it would follow that that would be from the trauma, kind of logically. And so that's that this is why this is worth to talk about. Here's one of the cervical spine. So it's the same sort of concept, and this is a high intensity zone of the cervical spine, and so that would be very unusual in an asymptomatic patient. So another significance of these, annular tears and fissures, they can be degenerative. I mean, certainly their annular fissure tears can occur on a degenerative basis, actually quite commonly. But one thing they can do is they can cause chemical leakage of substances. So the disc is torn, and there's this inflammatory reaction which can cause radiculopathy. So I always try to look very carefully for annular tears, because sometimes it will match what a clinician finds in terms of new radiculopathy. So that's the importance of these. I think they're always worth mentioning wherever you see them in anywhere in the spine, even if they're small, because of this phenomena. And they also tend to be stable. So this is a great article called Serial Imaging of Annular Tears, and it found that most patients that had annular tears, and they were presumably degenerative annular tears in these patients, that they were pretty much stable over time. So, when I've seen trauma patients, sometimes I see that these annular tears change in size, sometimes significantly, and then that could be due to the trauma or healing changes from the trauma. So it's worth mentioning. So hopefully we're not running too short on time here. We'll try to move a little fast here, alignment here to talk about this. But when you see malalignment, it can be seen with instability or ligamentous injury or laxity, but it can also be seen in older patients on a degenerative basis, maybe in some unusual congenital conditions as well. But malalignment in older patients, it's tough to relate it to trauma unless there's some other findings, or as maybe we'll discuss. But this is called anterolethesis, is when the vertebral body subluxes anterally, and retrolethesis when it subluxes posteriorly. So I'll show some examples, we'll show some examples later of that. But this is a normal cervical spine, how it arches back in the alignment here. And this is straightening of the normal cervical lordosis. So the patient is kind of a little bit hunched over. And then this is reversal. So it's actually, instead of going back, it's reversed. And the significance of this is that these findings can be seen in muscle spasm or in strain. Now, someone could say could be positional if the patient was, putting their head down, or if it was maybe they already had pre-existing altered biomechanics. And so, that's often possible. But these are important, I think, for the radiologist to describe these in the event that they're associated with strain or spasm. So here's a case where there's reversal of the normal cervical lordosis, and this would be a normal. And so that could be secondary to strain and spasm. And also the same with dextral curvature or tilting. So this patient was, the time of trauma was pretty close to here. And you could see that they have some curvature there. And you could say maybe that's just a scoliotic curvature. A lot of people have abnormal curvatures in their spine. But then on the follow-up exam, it was straight. And so when you see that difference, you could say, well, maybe they had a spasm of these muscles on this side that kind of tightened because of the spasm or strain from the trauma. And then, the clinician would have to confirm it. It's not something that you can say definitively, but you can certainly talk about these differences and say that could be a cause of that. So when we're talking about these anterothesis, the disability here is the cervical movement, anterior and posterior rotation greater than 3.5 millimeters, thoracic 2.5, and lumbar is 4.5. So if it's more than this, these are pretty highly associated with disability. And the degree of impression fractures also, so you want to talk about the heights of the fractures, and that's from the permanent impairment. But it's good for radiologists to know this so that we can look for that, not just flippantly measure, something, like actually accurately measure it because it can make a big difference, for the patient. Angular motion, I think chiropractors talk about this quite a lot. I've done this a little bit, but more on the anterothesis more than the angular motion, but that's also in this permanent impairment. So here's some examples. So this is a patient, maybe we'll start with the normal. So this is the normal, and this is dynamic flexion extension x-ray. So the patient's arching back. Flexion, they're arching forward, and that's showing the normal disc. And then this patient, you can see that these are normal, but then this one, the C3 vertebral body goes really far back on extension, and then it also goes forward on extension. So that was 3.5 millimeters of total translation at that level. And so this patient would be, based on those standards, in the right clinical setting, would have could have a disability or could have an injury. Ligament injury or laxity can cause that. So here's a pretty another example, and I've drawn these yellow lines just to kind of show the pathology. But on the flexion, it went anterior, and then on the extension, it went back, and that was a pretty significant difference at that level. So that would be again consistent with ligamentous laxity injury and with a poor prognosis by the ADA. So here's a case which it's not 3.5 centimeters, but 3.5 millimeters, but 2, 3, 4. This is C5 going back on C6 in extension, and it reduces in flexion. So it definitely should be mentioned that there is some differences there. Again, that's the normal. And what's helpful for this, even if this this didn't reach that threshold for disability or whatever, but it can be seen with ligamentous laxity or injury and stability. And then this patient ended up having a fusion at that level. So they had the fusion, and so when you describe the imaging findings, then it supports supports the fusion. It supports the neurosurgeon that did the surgery, where there was some imaging findings showing abnormal translation, and then it resulted in the surgery. So there's a very unusual case, post-traumatic arachnoiditis, where these nerve roots can clump from trauma. Haven't seen very many of this, but that is something that's been discussed. Syrinx, post-traumatic syringohydromyelia, where you get a cystic cavity in the center of the cord. Here's an article talking about it. And there's also, these can be associated with Chiari malformations, or they can be idiopathic, meaning no cause, but they can also be traumatic. So if you see this, especially changes over time, then that's something that radiologists can mention as a possibility. This was, maybe I won't get into this case. It's kind of a complex case where the patient was imaged over multiple times, but what we found on this case was that they had, and I measured this disc herniation very precisely at all these different time points, and we found it matched with the area of the syrinx in the center of the cord. So it showed the healing changes, and it showed the worsening of the disc herniation, accelerated degenerative changes with the syrinx. So this was took a lot of work, but it was really neat to see that. And the syrinx, disc herniations and syrinx can be related. And here's the article that talks about it. So it's only a case report, but there's other support for that, where they found that disc herniations have been associated with these syrinx. So the patient has a syrinx, then that association is interesting to know about. All right, so we'll finish with hardware complications, then we'll have any questions. And sorry for going over time here, but
hey, Dr. Snyder, before we get to hardware complications, I have a question.
Yeah.
So often enough in these cases, the go-to defense is, well, it's minimal impact. It couldn't have caused a herniation. It couldn't have caused a bulging disc. It couldn't have caused whiplash. From a neuroradiologist perspective, is there any truth to that argument that the force of impact, can determine whether an injury occurs or not occurs?
Well, it's not really an imaging question, so maybe I won't have a great answer to that. I just focus on the imaging findings, and of course, the worse the trauma, generally the worse the imaging findings. So it's very helpful from the imaging to have a good correlation. But we have seen pretty significant disc herniations where the trauma is not that significant. For example, there's the stories of people that just sit down the toilet and all of a sudden they can't walk because they sat down and when they were bearing down the pressure, the thing was just ready to burst and then it just burst. So you don't have to have an acute disc herniation. It's not necessary that there be a huge traumatic force, but generally, and they can occur. Disc herniations can occur even without trauma. They can sometimes be acute, but to say that the patient happened to have an acute non-traumatic disc herniation at the same time that the trauma occurred is a little bit of a stretch, I think. But
all right. Okay.
Yeah. So briefly, hardware complications, and this is something that I've probably gotten a lot more familiar with in the past year or 2 years dealing with these cases. And this is really important for these patients. And working with attorneys on these, both I work with defense and plaintiff attorneys on these. They really focus on this. I think Hugo, correct me if I'm wrong, but I think it's because of the medical bills that have resulted from these surgeries. So there's a lot of focus on these patients that have multiple surgeries from trauma. That there's lots of fighting about, well, what's it? Is it from the trauma or what should be paid for that? So
right.
This is kind of I think it's a big focus. So one of the things that we can look at is malalignment, hardware fracture, hardware loosening, and pseudoarthrosis. So I'll kind of go through these things. So trauma and pseudoarthrosis. So pseudoarthrosis is when the patient has a surgery and then it doesn't take. And a lot of times patients will have surgeries and then it'll take a couple months. It'll take 3 to 6 months, maybe even up to a year, to actually heal. And then they have a trauma in between that time. And so they can get a pseudoarthrosis, or they can develop a pseudoarthrosis. And so this is the article that talks about how, quite a few of these patients of pseudoarthrosis had a traumatic episode. And the traumatic episode caused the pseudoarthrosis, according to this article. And these are other articles that talk about this. So these are, the support for the opinions that a pseudoarthrosis could be from trauma. And that, this does require clinical correlation, but the radiographic features of pseudoarthrosis, can be described. So malalignment. So this is a case of where this was a pre-accident X-ray, just as a follow-up, and drew the line between the posterior vertebral bodies, and it looks, pretty flush. And they had the trauma, and all of a sudden the vertebral body is back. So there was a retrothesis soon after the trauma that was not there before, and then it got worse when they were imaged, a year later. So this is the posterior vertebral body that was back. So this patient needed a surgery, a revision surgery, from this, where they were. So the alignment is something that's really helpful to look at in these trauma cases. And this is what a pseudoarthrosis looks like. So they had the trauma here, and then this was the day of the CT. And the pseudoarthrosis, one of the findings on CT is that there's not fusion of the end plate. So this should all be white, should all be calcified. And this is the right side and this is the left side. And they kind of go out to the sides, you can see the whole thing. So that was a pseudoarthrosis in this patient that had a history of trauma. Now, hardware fractures also have seen these. So they had the trauma, and then they had this, and there was a screw fracture that was not there before the trauma. And then, we saw it again here. And then they had to do the revision surgery, and they actually had to leave the head of the screw in there because they couldn't, I guess, get it out. So they left it in there, but they took out and revised it. So that's an example of a hardware fracture from trauma. Loosening is the other thing that can be exacerbated by trauma, or caused by trauma, or it could just be caused not from trauma. You can see loosening in patients without trauma too. But these are the screws, and there's lucency around them. So this little area here surrounding the screws is secondary to some loosening. And you can see it to a little lesser extent here and here. And so that was a patient that had a hardware failure. And here is a sagittal view. This is a sagittal view, and these are normal screws. So this is how the screws should look, where there's no around them. And then here's the loosening. So there is that little area of lucency surrounding the two. So that's loosening, and that's hardware failure, and that can be caused by trauma. And there is another example, and this is showing the normal screws. And here's a case of progressive hardware loosening, and you really have to zoom in and window this to get this picture, but the trauma was here, and then this is the sagittal image, and there you see some loosening, and then you can see it getting bigger. So this is the lucency is bigger, and then here it's even bigger. So as time progresses from the trauma, this loosening is progressive, and they needed a revision. And so the question was whether that was from the trauma in this case, and it's quite helpful to to document that in this way. And this is, I think, the last case, just showing a very bad case of many things, but these are some acute fractures of the vertebral bodies with these acute margins going through there. And then the worst thing about this case, there's another fracture here of the anterosuperior 5 plate, was that the actual intrabody disc fractured into the vertebral body. So this is supposed to be like a graft holding the vertebral body. And there's one here too, and both of these from this trauma went into the vertebral bodies. So this was a very bad case with multiple fractures, multiple hardware complications, and I'm not sure what the outcome was of that, but it was a terrible case. So finally, the last thing to note is that the prognosis of any spinal injury and the risk of future degenerative disease increases with injuries. So if you have a ligament injury, if you have a disc injury, if you have a annular tear, or of course a fracture, your risk of future degenerative changes will increase. So that patient will, throughout their whole life, be at increased risk for increased degenerative changes at the levels injured, and these are the support for that. And also, if you have surgery, you have increased degenerative changes above and below the levels of surgery because of the altered biomechanics. So if you fuse C4 and C5, C3 and C4 will have increased degenerative changes, and C5 and C6 because of the altered biomechanics. So sorry we went a little long if we did, but this was hopefully you all enjoyed this, and maybe there's some further questions or comments from the moderators.
Yeah, no, that was great. We've been, we try to knock out the questions as we go. I think we just actually had two, and then we can turn it back over to Ginger. We had one question. Why or how do some herniations reduce in size? For example, an 8 millimeter, then a 4 millimeter in subsequent MRIs.
So that, yeah, if you have a disc herniation, if you have trauma, and then you have a disc herniation that's seen on a subsequent MRI, and then if you do a follow-up MRI and it gets smaller, then that would be consistent with a healing change from trauma. And if the question is whether large ones tend to reduce more than smaller ones, I think that's probably my experience. The larger ones may, if they're traumatic, will heal. Will get smaller rather than smaller ones, but I'm not sure there's any studies that have been done on that.
Gotcha. And the last question was, other than surgery, are there any other treatments or physical therapy for whiplash?
That's a good question. I don't know the answer. Yeah, I would defer to my clinical colleagues who maybe treat those patients, and maybe there's some physical therapy that would be I mean, I know that's used for a lot of things. Whether it's used more for whiplash or not, I'm not sure.
Sure. Well, that was just an awesome program as usual. Tons of questions, and appreciate all the information from both you and Hugo and the feedback. Ginger, I think we're going to go ahead and turn it back over to you.
Absolutely. That was amazing, Dr. Snyder.
Oh,
And
thank you.
I'm going to tell you, you would believe some of the messages I was getting behind the scenes. Everybody was saying, oh my gosh, we need a copy of this, or how can I reach out to him? And the good news is we did record today's webinar. I will be sharing a copy with all of you who've watched today, and we'll be posting it on HMR's website, as well as our Connectionology YouTube page. And as well as the questions that I had about, can I get a copy of the PowerPoint? Absolutely, I will email you a copy after this webinar ends. And then like Dr. Snyder said, reach out to them. If you have any questions after this, this is why I love our community so much, because you guys, you're not afraid. Just pick up the phone and ask questions, meet each other. I mean, it's the whole reason why we do this. And again, I'm hoping one day we'll get back to our live seminars, hopefully later this year. We're going to start doing them across the country. But until then, we're going to keep these wonderful webinars available to you. I've got several of them coming up in March. I'm going to start adding them to our website. I'm going to show you a couple things real quick. And then I'm going to introduce Paul, who is our other amazing sponsor. I see you, Paul, that you're here with us today. But let me show you real quickly the information that I'm going to email you. Again, Dr. Snyder just showed you some of his contact information, but I'm going to send this to you along with his slides. And then I wanted to also let you know that we do not have any webinars next week, because we are going to be supporting the Florida Justice Association's 2021, I still can't believe the year. They'll be doing the Workhorse Seminar with John Romano. I believe this is the 36th year running. And this is an incredible seminar. You guys are all invited to it. I've put some information on our website, connectionology.com, so you can check it out. But this is 4 days of an intense work. We're talking 7 a.m. to 10 p.m. and they got things running all day long. But you can learn so much. And then, like you said, you can get 50 plus CLE credits. So please check that out. We will be supporting him. And now I'm going to loop back in. We've got two big announcements. First one is we've got this cake giveaway. It is our last one of this month until we move back to the coffee giveaway with HMR. But before we do that, I'm going to loop in, and I want to introduce you to Paul, who is an amazing, amazing guy. Lives in Atlanta, Georgia, and he's been a wonderful sponsor for us for many years now. Paul, if you don't mind, tell us a little bit about what you do.
Will do. Thanks, Ginger. So my good friend, John Gomez in San Diego says, when you're suing a corporate entity, without exception, there's always a lie and there's always a cover up. They're going to hide the ball from you. And so one of the very best things you can do is harvest their own next employees. And I don't mean the ones they're giving you from out of discovery. I'm talking about the ones they wish you had never found. This is what we've been doing for almost 20 years. We harvest the X's from the bad guys and we turn them into whistleblowers. Hugo, this one I call Hugo because it's 24 karat, man. I call this Hugo. It's my name for my whistle here. But honestly, we're doing this in drownings, burnings, products cases, trucking, of course, elder abuse, everything you can imagine from coast to coast. And it's causing sort of a revolution in a lot of law firms' practices in that they're able to get right to the core of the evil that was taking place due to the negligence of the defendant. So I put my information in a little earlier. Connor McDuffie, if you call or text him, he'll send you a redacted exemplar of one of these. We call him an eel. Hey, Hugo, an eel, an essential ex-employee list. And here's eel, right? Here's L, the happy eel right around my neck, you know. So they have a tendency to send an electric charge through cases. If I have anything to do with it, Hugo, we're going to electrocute your defendant. So get in touch with us.
Thank you so much, Paul. We really appreciate it.
Thank you.
And again, we hope to see you back in March, okay? Because again, we've got a lot more great webinars coming up. And I really just want to thank HMR so much for doing this webinar with us, for making it happen. We can't do this without you guys, and you did a wonderful job today. Dr. Snyder and Hugo, Kyle, thank you so much for everything.
Got it, no problem.
Thanks, everyone. It was a lot of fun.
Awesome.
Have a good day. Bye, everybody.
Wait, before you go, I want to give you the winner.
Oh, yeah.
Yeah, no worries.
Yes, thank you for reminding me.
No problem. So the last king cake goes to Sophia Zampano with the Lerner and Rowe Law Firm out of Arizona. So,
Yay. Congratulations, Sophia. And by the way, I tried some of this cake yesterday. It is delicious. And actually, it's freshly baked right out of New Orleans. So you're getting an authentic cake. So congratulations. Thanks, everybody.
Bye, guys.
Thank you.
Bye.